Dear colleagues, I would like to present my progress from the last 6 months in my PhD topic, which is about treatment possibilities in oro-maxillo-facial rehabilitation. I'm from the Department of Prosthodontics, and my vision is an evidence-based maxillofacial prosthodontics, because currently we are just improvising case by case, and my mission is to achieve this, to establish the foundation for a proper scientific output. Here are my specific goals to achieve this mission. And my first project is about extraoral 3D scanners. If you are trying to fabricate a facial prosthesis, you first have to obtain a model of the patient's face. And currently, we have to take an impression of the patient. But nowadays, digital face scanning systems are really popular, but not yet validated for this specific clinical purpose. So that's why we set out, our aim is to compare distances between landmarks of the face, and these landmarks are measured, or were measured directly on the patient's face with a caliper, and later on the three-dimensional model on the computer, the same measurements were done again. And the difference between the measurements will give us the accuracy of the 3D models. Our null hypothesis was that there's no difference between accuracy between the technologies and between facial regions. We conducted a systematic search in 5 databases, and at the end of the screening and reading all the papers, we included 11 articles in this review. The risk of bias assessment was done with the QuadAS2 tool by tailoring the signaling questions to this specific review by adding a question and omitting one. Overall, most of the papers showed low risk of bias. However, in 2 cases, there were some concerns. We plan to conduct a regional analysis by assigning an interlandmark distance to a certain region of the face and to a certain axis in the 3-dimensional coordinate system. But due to data insufficiency, this was not suitable or not feasible in the auricular and in the periorbital region. At the end, we got 7 forest spots, but due to time constraints and due to their similarity to each other, I'm only showing you 3, 1 from each region. So what we can see here is the differences between the measurements, between the direct and the virtual measurements, will give us the accuracy of the 3-dimensional model, which later is the reason why we have an accurately fit final prosthesis. The heterogeneity is quite low, that the I-square test shows, and the effect size here is expressed in standardized mean differences, which are made up numbers, so to say, but since the point estimates are really close to the null effect line, the unit of measurements is not that interesting. And at the end of the statistical analysis, we have a narrow confidence interval, which means that pulling all the articles population removes the imprecision that otherwise is well, in the individual articles. So this narrow confidence interval solidifies our certainty of the accuracy. Here you can see the summary table where the green shows a slight magnification, so a positive difference, and the red shows a negative difference or shrinkage. Between subgroups, there were no significant differences, but laser scanning systems are a bit underrepresented in this field due to the longer capture time. But of course, structured light system and stereophotogrammetrical systems also has some difficulties that were reported in the included papers. The grade assessment first showed that we have a low level of certainty of evidence because we included only observational studies. However, we could argue for upgrading because these cross-sectional study types are the best possible study types for this assessment. And all the authors has done some effort to eliminate confounding factors or potential biases. So we concluded that we have a moderate level of certainty. The strength of this review is that no regional analysis was conducted before in the human face. The same methodology was used throughout all the articles, and at the end of the statistical analysis, we have a narrow confidence interval. The limitations are that not all regions were involved in the analysis, and the population is not representing purely the people of interest, because only healthy volunteers were in the papers. The control measurements are just an indicator, since this is not a procedure in facial prosthetics, meaning the direct measurements on the face. So the conclusion is that this is only just a beginning. If you are switching the impression with a scan, the whole artistic nature of the whole workflow is only just shifted into the digital world. However, the clinical implication would be that the three-dimensional scanners are accurate enough for further work, and since they don't have the disadvantages as traditional impressions have, these are preferable over traditional impressions. The research implication is for further work with people with facial deficits and the learning curve of the usage of facial scanners, and on the later stages of the fabrication of facial prostheses. As for the progress goes, we are at the manuscript writing stage. My second project is about different treatment options for patients with maxillary defects. These defects come from surgical ablation due to cancer treatment, and the increasing number of the patients who are surviving cancer and still needing some rehabilitation afterwards we need a common solution, we need a good solution for everybody, and the choice between the restorative surgical and the prosthodontic treatment options is still controversial, because it depends on the doctor. This is who is responsible for the rehabilitation. So our aim is to compare all the possible interventions that is suitable for these kind of patients. And at the center of this map, you can see that the conventional obturator dentures are there. So that's why our PICO framework set out that the conventional obturator would be the comparator, and the other restorative surgical or prosthodontical interventions would be the eyes. The quality of life is what the outcome is, which is assessed through two standardized questionnaires that specifically tailored, that they are specifically tailored for head and neck cancer patients. And a null hypothesis is that there are no differences in quality of life between these interventions. And if this is the case, then since prosthetic treatments are much more cost-effective, easily modifiable, and less of a burden for the patient and for the doctor, if they have the same efficiency, then this could be another or widely popular option. My third project has the same framework as the second one, but this one focuses on soft palatal defects. And the unmet need here is a protocol, a widely accepted protocol for the fabrication of a prosthetic appliance that restore the function of the soft palate. And we don't have that currently. So not many centers can provide this kind of prosthetic treatment for the patients. But if we can prove the non-inferiority of this solution, then this can be the first step of popularizing this option as well. Well, I would like to thank you for your kind attention with a quote by a race car driver, Mario Andretti: "If everything seems under control, you're not going fast enough." Thank you.
Just only one comment about your lectures, not just only the dentist sensitive, it's technical sensitive, this area of these fields of this dentistry, because you know it's always a high challenge for the everyday practice to solve and restore. This is non-manageable or very complicated cases. So I'm turning to the...
Thank you very much. As usual, it was very interesting. So regarding the third project, I just want to ask your coming plan. What is your further plan? And because due to the time restriction, you don't have any chance to talk in detail, but I'm just interested, what is your plan? And are you going to work with patients, or are you planning to do systematic review, or?
With the last project, you mean? Yes. My plan is to write a proof of concept study regarding different fabrication steps for getting the same results. I mean, a prosthetic appliance for soft palatal obturator. So, yeah, so proof of concept studies are the further plan for this project.
So, for the first project, how does your results help for the clinical practice? And so,
there was a question that whether if these scanners are suitable for this specific purpose, and it came out that they are. So the further questions are regarding the further steps of this workflow, meaning that if we can ditch all the impression taking, all the cast fabrication and everything, then we could get maybe much more cost-effective, a faster, and a less technically sensitive treatment options for these patients.
Is there any possibility to make like electron data bank regarding this data? Because it seems like there's a lot of data, and so you summarize all of this anatomical measurement and put this data, and maybe somehow other researchers can use this data, right? What do you think about this idea?
I'm not sure I understand your question. Whether if it's, what kind of data bank are we talking about? Well, we set out that maybe for patients who don't have any ears, so not just one-sided defect, then we can have a bank of shapes of ears that can be used for a patient with no ears whatsoever, for example.
With your last topic, that do you actually plan at the end developing some special device? So would this the purpose? And if so, then what kind of device?
No device is planned, but a protocol that, because most dentists, if a general dentist is looking at a patient like this with no soft palate whatsoever, he immediately or she immediately, cancels the whole thing, and no real treatment plan is fabricated this way. So we need a protocol for centers who can provide this kind of treatments.